It's a pleasure to be with you. The title of this session is Ecologic Models and Public Health Practice. There are no disclosures for this presentation. Objectives include review the concept of ecology and public health, discuss the differences of ecologic models used for infection control and those for chronic diseases, review the 6 eras of public health, discuss the differences between health promotion and population health approaches to health, review the PRECEDE, PROCEDE, and health impact pyramid models and how they relate to health promotion and population health. Ecology is the study of how organisms interact with one another and with their physical environment. The ecological approach views people as embedded in their environment, both social and physical. People influence their environment and in turn are influenced by that environment. The 1959 book Mirage of Health by René Dubos provides an example of how ecology relates to human health by describing how microscopic fungus that destroyed the potato crop in Ireland in 1845 and 1846 caused a tuberculosis epidemic in eastern U.S. cities in the mid-19th century. International exploration and trade by Europeans after the 15th century brought a South American native plant, the wild potato, from the Andes to Ireland and elsewhere in Europe. Potatoes produced more calories per acre than wheat and therefore became a major food staple, particularly for poor families. In the early 1800s, a strain of potato fungus causing potato blight spread through the Americas and onto Europe in the 1840s, where because of an extreme lack of genetic diversity, the potato crops were devastated. This blight was particularly severe in Ireland due to the dependence of the poor on this single staple crop and resulted in a mass immigration from Ireland to the United States. Many of these immigrants took up residence in the crowded, unhealthy conditions of tenements of industrial cities along the Atlantic coast. These unhealthy living conditions resulted in the transmission of many contagious diseases, including tuberculosis. The dramatic increase of tuberculosis mortality in Philadelphia, New York, and Boston around 1850 can be traced in large part to the Irish immigrants who settled there. Dubos lists the multiple political, economic, and cultural causes for this epidemic, clearly demonstrating the impact of ecology on health. The environment or context in which people live influences how they live and their health outcomes, for better or worse. Public health attempts to maintain or create healthy environments in which people live and prevent or dismantle unhealthy ones to promote health and reduce morbidity, disability, and premature mortality. The way public health attempts to affect the environment or context is the story of public health practice and reflects public health ecological models. These models are not static but kinetic, changing as needed to respond to health problems predominant at the time. For example, where infectious diseases are predominant, models reflecting their spread and control are required, like the epidemiologic triangle. This model is not only useful for infectious diseases, but also for other health problems, chemical, physical, nutritional, etc., and includes traits of the host, environment, and agent to help understand and control an outbreak. For an infectious disease outbreak, the agent is a biologic or microbial organism, virus, bacterium, protozoan, prion, fungus, etc. The host is the organism that harbors the microbial agent. The environment includes all the factors that influence transmission of the agent or susceptibility of the host, and could be aspects of the natural, built, or social environment, including policies. Time attributes are particularly important for infectious outbreaks and include the time between exposure to the agent and illness onset, the incubation period, the time period an infected host is contagious to others, the time it takes to recover from illness, and the time it takes for an outbreak in a population to resolve. Prevention measures aim at disrupting the relationship between at least two of the triangle factors: agent, host, and environment. Friss and Sellers discussed the environmental factors to consider during an infectious disease outbreak. The external environment is a sum total of influences that are not part of the host and comprises physical, climatologic, biologic, social, and economic components. The physical environment includes weather, temperature, humidity, geologic formations, and similar physical dimensions. The social environment is the totality of the behavioral, personality, attitudinal, and cultural characteristics of a population. Both physical and social environments impact agents of disease and potential hosts, since the environment may either increase or decrease the survival of disease agents, influencing the transmission potential between agents and hosts. This is an important statement. The epidemiologic triangle model works well for most infectious disease outbreaks since they generally have a single agent, but it may not be as helpful for other diseases or health problems. The wheel of causation is another ecological model. Peterson notes, although it is not used as often as the epidemiological triangle model, it has several appealing attributes. For instance, the wheel contains a hub with the host at its center. For our infectious disease example, humans represent the host. Also, surrounding the host is the total environment divided into the biological, physical, and social areas. There are considerable interactions between the environmental areas. The wheel of causation illustrates the multiple etiologic factors associated with human infectious diseases. In general, every ecological model explaining health or poor health contains a set of distal causes related to the environment, like the physical, social, and biologic areas of the causation wheel, along with a set of proximal causes related to the individual, primarily behavioral. One of the major considerations in developing public health models is where to place the emphasis. Public health could focus efforts on changing individual behaviors directly, or on changing the environment in which individual behaviors occur. For example, after examining Dubow's description of the development of the tuberculosis epidemic of the 1850s in northeastern cities of the United States, public health might decide that tuberculosis could have been prevented by focusing on the sanitary behaviors of Irish immigrants to reduce person-to-person transmission of disease. Targeted behaviors might have included hand washing, housekeeping, food preparation practices, and so forth. Changing behaviors might also have included encouraging compliance through education or coercion through policies, rules, and laws. On the other hand, public health might decide that the tuberculosis epidemic could have been prevented by changing the social, political, or physical environments. If the cities to which the Irish emigrated had provided more healthful housing and working conditions, the Irish immigrants would not have been as susceptible to illness, including tuberculosis. They might have targeted the crowding and other relevant conditions in neighborhoods where immigrants came to live. So instead of motivating individuals to change their behavior through education, public health might argue that they could have changed the physical environment to reduce the spread of tuberculosis. Stepping further back in the causal chain, public health might decide that the political environment in Ireland should have been the focus of intervention. If England had provided aid to the Irish during the potato blight, the Irish would not have perished in such numbers, and survivors, poor and already weakened by famine, would not have sought immigration to the United States. Going back even further, public health might decide that the undiversified diet of the Irish should have been the subject of intervention. If the Irish food supply had been diversified, the potato blight would not have become a crisis for that population. Political decisions in England likely influenced the tuberculosis epidemic in the United States. A different political posture could have changed the environment and prevented this epidemic. Public health might decide that the answer is not either or, but both and. Yet to focus on both individual behaviors and environmental issues at the same time will require more resources, which may not be possible. With limited resources, which is not an unusual situation for public health, leaders may be forced to make difficult decisions and focus on one or the other target areas for interventions. There are essentially 6 eras of public health history. 1. Health protection. From antiquity to the 1830s, that focused on authority-based control of individuals and communities and prohibition of certain behaviors. 2. Hygiene movement. From 1840 to the 1870s, focused on implementation of sanitary control of infectious diseases. 3. Contagious disease control. From 1880 to the 1940s, focused on the application of infectious disease germ theory and techniques to control infections. 4. Filling medical care system holes. From the 1940s to the mid-1980s, focused on the integration of various disciplines to control infectious diseases, along with the modification of risk factors associated with chronic diseases. 5. Health promotion and disease prevention. From the mid-1980s to 2000, focused on clinical and population-based prevention of infectious and chronic diseases. 6. Population health. From 2000 to the present, focused on the coordination of public health and healthcare and shared evidence-based systems thinking to control and prevent infectious and chronic diseases. As can be seen, from the 1940s, there was a transition of public health to focus not only on the control and prevention of infections, but also chronic diseases. This shift resulted in the need for new ecologic models to address chronic diseases. Ecologic models must be flexible to meet the needs of current health problems. New models developed since the 1960s to address chronic diseases represent a significant departure from the classic models of the epidemiological triangle and the wheel of causation used primarily for infectious diseases. The model on the right side of this slide is a socio-ecologic model for health promotion and includes 5 intervention targets, including strengthening communities, enable, mediate, advocate, reorient health services, create a supportive environment, and develop personal skills. By the 1980s, ecologic models transitioned to focus on educating and motivating individuals to stop smoking, lose weight, increase exercise, eat healthier foods, use seat belts, avoid unprotected sex, screen and treat hypertension and elevated cholesterol, etc., rather than focus on the context or environment influencing the health of populations and individuals. These models were titled Health Promotion and Disease Prevention. As Green stated in 1999, 1974 was a turning point when health promotion was accepted as a significant component of health policy. New national health promotion programs were established, including the Office of Disease Prevention and Health Promotion in the Department of Health and Human Services, and the Center for Health Promotion and Education at the CDC. The focus of health promotion and disease prevention contrasted with historic interventions such as sewage disposal or food inspection, which emphasized changing the environment. By and large, health promotion programs use Green and Kruder's PRECEDE model for conceptualizing community health promotion and planning. PRECEDE was developed in the 1970s. PRECEDE stands for predisposing, reinforcing, and enabling constructs in educational diagnosis and evaluation, essentially education planning. As its name implies, it represents the process that precedes or leads up to an intervention. PROCEED stands for policy, regulatory, and organizational constructs in educational and environmental development, or education implementation, and true to its name as well, describes how to proceed with the intervention itself. The model focuses on improving health by changing an individual's behavior through education and not toward intervening at the environmental level. PRECEDE's predisposing constructs include a person's or population's knowledge, attitudes, beliefs, values, and perceptions that facilitate or hinder motivation for change. Reinforcing constructs include rewards and feedback a learner receives from others following adoption of a behavior. That feedback may encourage or discourage continuation of the behavior. Enabling constructs are those skills, accessibility, resources, or barriers that can help or hinder behavioral and environmental changes. There is a very restricted view of the environment under enabling that's limited to the immediate setting of the health education program. PRECEDE focuses on improving health by changing an individual's behavior through education and not toward intervening at the environmental level. Education about the risks of certain behaviors and the benefits of others, health diet, exercise, substance abuse, smoking, seatbelt use, is a primary component of health promotion. Once knowledge about health behaviors is conveyed, an individual must be appropriately motivated to change risky behaviors. Knowledge and motivation are both needed to effect behavioral change. This is an adapted and simplified early PRECEDE model. The steps to implement this model start with PRECEDE assessments, including social, behavioral, and current educational, organizational, policy, and regulation data and information. These assessments provide valuable formative information to develop an intervention plan that includes policy, regulation, and organizational components, and a health promotion, education, and training plan. The intervention or implementation of these plans influences the predisposing, reinforcing, and enabling constructs that influence behaviors and lifestyle, the ecosystem and health, and ultimately the desired outcome, quality of life. A major tool of health promotion is the application of psychological theories to understand why people engage in unhealthy behaviors and how to motivate people to modify them. These theories include the health belief model developed by Becker, 1974, the theory of reasoned action by Adjzen and Fishbane, 1980, the protection motivation theory by Rogers, 1983, the social cognitive theory by Bandura, 1986, which emphasizes self-efficacy, and the social learning theory by Rosenstock, Strecker, and Becker, 1988. Health promotion was common through the 1990s. One argument for this approach was that social environmental factors, including cultural, economic, and political issues, were thought to be too complex and difficult to address versus individual behaviors. Another argument was a desire to contain healthcare costs. Changing an individual's behaviors by health promotion education would improve their health, make them better informed consumers, and ultimately decrease their need for healthcare services. Placing the accountability for poor health on the individual is a major criticism of the health promotion model. Viewing the individual's behavior as the major problem to fix, while downplaying or ignoring the environment or context in which that behavior occurs, was seen as inappropriately blaming the victim. The environment in which people live significantly influences their behaviors, and so solely blaming individuals for having poor health behaviors when they live in an unhealthy social environment is ineffective and unfair. For example, poor people in minority groups often live in neighborhoods where access to healthy foods like fruits and vegetables is limited, with high-fat, high-sodium snack foods of little nutritional value commonly more readily available. Does the fairer and more effective public health intervention aim at improving the diet of people in such neighborhoods by targeting the eating behaviors of residents themselves, or the social environment issue of healthy food access? Situations and questions like this were being raised regarding the PRECEDE health promotion model. Not surprisingly, in the late 1980s and early 1990s, the pendulum began to swing back to a focus on environmentally targeted interventions and an interest in understanding the interaction between individuals and their environment. Because of the blaming the victim argument, as well as the recognition that health education was not as effective as expected, interest in alternatives to health promotion intensified. Green and Kruder revised the PRECEDE model in 1991 to place more emphasis on the environment or context of behavior that includes adequate housing, secure income, healthful and safe communities and work environments, enforcement of policies and regulations controlling the manufacture, marketing, labeling, and sale of potentially harmful products, and the use of these products, such as alcohol and tobacco, where they can harm others. The model now contains a box labeled environment. This change in the PRECEDE model now assumes that individuals are affected by their environment. The PRECEDE model was once again revised in 2022 to include the evaluation of programs. The evaluation of PRECEDE interventions would include process, impact, and outcome evaluations. This is a diagram of a later PRECEDE model that includes an evaluation component and an environmental box that's influenced by enabling constructs, behaviors, and lifestyle. The environment then in turn influences behaviors and lifestyle, the ecosystem and health, and quality of life. Although the revised health promotion PRECEDE model placed more emphasis on the environment, the focus was still on providing a blueprint for changing the individual's behavior through education and relying on psychological theories for understanding how to motivate behavioral change. Environmental changes within health promotion programs are still limited to the immediate environmental setting, not addressing social structures or larger environmental factors. At the same time health promotion was being questioned, the concept of population health was introduced. It focused on the social environment, power, wealth, and status as the root cause of health problems, supported by a large body of research demonstrating health disparities between the rich and the poor, the powerful and the powerless, and those of high versus low social status, supported by research providing conclusive proof that an individual's social status, wealth, and power have a profound influence on his or her chances of being healthy. The Whitehall study was one of the first to demonstrate that people who are structurally disadvantaged are far more likely to have poor health. Population health is the sixth and current era of public health, shifting from health promotion in the early 2000s. Studies have asked, why do some people exercise and others do not? Why do some people eat nutritious foods and others do not? Why do some people lead sedentary lives and others do not? Why do some communities have support groups for behavior change and others do not? Why do some communities have opportunities for exercise and relaxation and others do not? Why are some communities free from toxic substances in the environment and others are not? A significant cause of unhealthy behaviors is the unequal distribution of power, wealth, and status that give the advantaged opportunities and resources to live in healthier environments, engage in healthier behaviors, and have access to better health care. Marmot in 2005 stated that the gross inequalities in health that we see within and between countries present a challenge to the world. That there should be a spread of life expectancy of 48 years among countries and 20 years or more within countries is not inevitable. A burgeoning volume of research identifies social factors, wealth, power, and status at the root of much of these inequalities in health. Social determinants are relevant to communicable and non-communicable diseases alike. The population health approach is leading to more complex public health models that integrate social, physical, environmental, and behavioral factors to predict disease, disability, and premature death. Health behaviors are viewed as patterned by the social environment, not freestanding. Population health pursues health equity by eliminating health disparities and inequalities. Everyone, not only the rich, the powerful, or those with social standing, is entitled to conditions that produce health. Public health historically has advocated for equal access to opportunities and resources for all. Though there has been a public health shift toward population health's environmental approach, there is still a role for encouraging a change in individual behaviors. The President's Cancer Panel report, titled Reducing Environmental Cancer Risk, What We Can Do Now, from 2008 to 2009, provides an example of the struggle between individual behaviors, health promotion, and environment population health approaches. That report found that a growing body of research documents myriad established and suspected environmental factors linked to genetic, immune, and endocrine dysfunction that can lead to cancer and other diseases. The panel advised that the true burden of environmentally induced cancers has been grossly underestimated, and argued that the burden of cancer had not been addressed adequately by the National Cancer Program, which focused on individual behaviors, screening, diagnosis, and treatment, and that there should be a shift to address environmental causes of cancer, including carcinogens from industrial and agricultural occupational exposures that have since found their way into soil, air, water, and numerous consumer products. The report stated that the current regulatory approach was reactionary rather than precautionary. A substance's danger must be demonstrated incontrovertibly before action is taken to reduce exposure to it. Therefore, the public bears the burden of proving that a given environmental exposure is harmful. The panel urged the president to act on its findings. But Michael Thune, Vice President of Epidemiology and Surveillance Research at the American Cancer Society, as reported in the New York Times, stated that the report was unbalanced by its implication that pollution is the major cause of cancer, and tried to refocus on the importance of individual behaviors to control cancer. Dr. Thune mentioned the term balance. There may be advantages in researching and finding the appropriate balance of population health and health promotion approaches to more effectively reach health goals. Both the individual and the environment or context are potential targets for public health interventions, and both have been employed throughout the history of public health. For example, in the early part of the 20th century, there were interventions that focused on the individual level, teaching and encouraging individuals in immigrant communities to engage in certain health behaviors, such as hand washing, that prevented infectious diseases, and those that focused on the environmental level, notably the environmental engineering interventions that brought clean water, safe food supply, and sanitary disposal of waste to these communities, also preventing the spread of infectious diseases. Neither approach was ever entirely abandoned, but in different eras, one may be emphasized over the other. Indeed, a study of tuberculosis control in the 19th and 20th centuries led Fairchild and Oppenheimer in 1998 to argue for a more nuanced approach to public health practice, in which strategies that address both individual and environmental causes of disease with broad and targeted interventions are employed. Decisions about how best to promote and maintain health in populations go to the heart of public health practice. Public health approaches flex with time and scientific knowledge. For example, let's consider the progression of approaches to obtain clean water. Water treatments were recorded as early as 4000 BCE and were generally focused on improving the taste and odor of drinking water by filtering through charcoal, exposing to sunlight, boiling, and straining. The association of water with specific diseases was dramatically shown by John Snow's work in London in 1854. John Snow lived from 1813 to 1858. He was an anesthesiologist by training. He studied the cholera epidemic in London and identified the cause, contaminated water, associated with the Broad Street pump circled on the map. Each mark on the map is the physical location of a case of cholera, and helped Snow deduce that the pump was essentially the geographic center of the epidemic and could likely be the culprit. Using that data, Snow developed a practical solution to the problem. Remove the pump handle, which Snow did. This picture is the famous Broad Street pump with the handle removed. Knowledge of disease-causing microorganisms increased dramatically during the remainder of the 19th century due to advances in the field of microbiology. Cholera, typhoid, hepatitis, and other infectious diseases were recognized as waterborne illnesses and controllable through water treatment. The first continuous water chlorination system in the United States was implemented for Jersey City, New Jersey in 1908. In 1970, public health focused on water pollution from pesticide residues, industrial waste, and organic chemicals, resulting in enhanced regulations and a variety of chemical, physical, and biological water treatments targeting pollutants. The history of clean water approaches demonstrate primary prevention interventions used for thousands of years. It also illustrates the transition of approaches from individual to environmental interventions that were influenced by advances in science, policy, and regulation. The Health Impact Pyramid, developed by PRECEDE in 2010, provides a useful framework for integrating behavioral and environmental approaches to public health practice. Socioeconomic factors are at the bottom of the pyramid and would include programs that deal with poverty, general education, housing, inequality, disparities. The next level is changing the context or environment to help individuals to default to health decisions. This would include fluoridation of water, smoke-free laws, tobacco taxes. The next level is long-lasting protective interventions, including vaccinations, smoking cessation programs, colonoscopy screenings, etc. The next level is clinical interventions that would include medications for high blood pressure and diabetes, etc. The top of the pyramid would be counseling and health education, including eating healthy foods, exercise, etc. The greatest impact on populations is at the lower levels of the pyramid, which deal with the environment of people, the area of focus for population health. Individual behavior interventions, or those associated with health promotion, are at the top of the pyramid and have less impact on populations. There is a role for both health promotion and population health interventions, but realize that population health will have a greater impact. Frieden suggests that structural inequality embodied in the socioeconomic factors is the level with the most potential to improve health, a primary prevention strategy. Also note that the second level, changing the context, is a primary prevention strategy which includes provision of clean water and safe food, as well as the passage of laws that prevent injuries and exposure to disease-producing agents. Interventions at the top tiers are a mix of primary, secondary, and tertiary prevention designed to help individuals rather than entire populations, but they could theoretically have a large population impact if universally and effectively applied. In practice, however, even the best programs at the pyramid's higher levels achieve limited public health impact, largely because of their dependence on long-term individual behavior change. Since its publication in 2010, the Health Impact Pyramid has been referenced by several organizations. An American Heart Association publication states, "The improvement in socioeconomic status is a worthy goal for any society, and the American Heart Association Community Guide fully recognizes the critical importance of the social determinants of cardiovascular disease." The report further argues that a combination of policies and programs at all 5 tiers will be the best way to improve health outcomes in populations. In summary, people influence their environment and in turn are influenced by that environment. The epidemiologic triangle and wheel of causation are ecologic models useful for control of infectious diseases. Early eras of public health focused on control of infectious diseases, with later eras adding control of chronic diseases. Health promotion focuses on changing an individual's behavior through education. Population health focuses on improving health by changing the environment or context. There is a role for both health promotion and population health interventions, but population health will have a greater impact.